Assalamu alaikum. Hello and good morning, everyone. First of all, I would like to express my gratitude to the organizers of the meeting for bringing us all together here today. It's truly an honor to be here and present our abstract among such esteemed colleagues and guests. I'm Samim Azizi, PGY4 cardiothoracic surgery resident in Hamad Medical Corporation, Qatar. Today I will be presenting our paper under the title of Coronary Endarterectomy in Patients Undergoing CABG, which reflects experience of Qatar over the last decade. My supervisors for this paper are Dr. Abdul Wahid Al-Mullah, Dr. Ali Kindawi, and Dr. Muhammad Latif Wani. So we do not have any conflict of interest. So when I talk about endarterectomy, it's not a new procedure. It's quite an old procedure. In 1950s, it was one of the only available methods for surgical revascularization of the coronaries. But because of the high risks to the patients and because of the introduction of CABG, it was kept off the table. But recently, we have some surgeons are considering to bring back this procedure to the table. So endarterectomy is a new flavor from the very old recipes. In 1950s, it was one of the first procedures. Currently, because of the introduction of the PCI percutaneous intervention, most of the cases which are being referred to cardiac surgeons are very diseased and diffusely diseased cases with anatomical complexity of the vessels. So more oftenly or more frequently, the surgeons would need to perform extra maneuvers to get a good distal runoff and get a complete revascularization. One of these procedures is coronary endarterectomy. But even without these procedures, many of the cases might be deemed inoperable or be refused by surgeons. On the other hand, there are other surgeons who do not like to perform this procedure, this carotid endarterectomy, because of the risks associated with it. So it's a topic of controversy. In this paper, the objectives of this paper is to compare outcomes of patients who underwent coronary endarterectomy plus CABG as compared to those who who underwent only CABG without endarterectomy. The primary outcomes were 30 days mortality, defined as all-cause death between 0 and 30 days. The secondary outcomes were post-operative MI, length of ICU stay, length of hospital stay, ejection fraction in 1 year, readmission need in 1 year, and need for reangiography in 1 year. So the type of our study is a retrospective study, and we reviewed and analyzed our patients who underwent isolated CABG in our center from July 2013 to December 2023. The population of our patients were the diverse ethnical and multicultural population of Qatar, including the locals and expats living in Qatar. We reviewed 3,013 patients. Out of them, 71 of them had undergone coronary endarterectomy while undergoing CABG. We created another group of 140 patients of those who underwent only CABG without endarterectomy by 2-to-1 propensity matched based on logistic Euroscore. Univariate analysis was used to compare preoperative, intraoperative, and postoperative variables between these two groups. So as we see, the preoperative demographics were quite similar among both groups in terms of the age, comorbidities, diabetes, smoking, or hypertension. The patients were quite similar because they were matched based on Euroscore risk. So the results of the study, as I said, intraoperatively, it was seen that cross-clamp time was longer in the coronary endarterectomy group as compared to those who underwent only CABG. Post-operatively, 30 days mortality was similar between both groups. Infective complications were slightly higher in the endarterectomy group, and this might be due to the longer operative time, because there are many papers reflecting that longer cross-clamp or longer operative times are associated with more infective complications. Otherwise, all complications were similar among both groups. After 1 year, again, the outcomes for chest pain, reangiography need, post-operative MI, and readmission rate were comparable and similar among both groups. So these are the findings. The only significant finding which we had was the cross-clamp time, which was longer in the coronary endarterectomy group, and the infective complication, again, it was slightly higher in the endarterectomy group with a significant p-value. So in conclusion, I can say that coronary endarterectomy, although it's associated with increased cross-clamp time, it did not contribute to additional adverse outcomes in terms of short-term post-operative complication, in-hospital mortality, or even in terms of long-term post-operative follow-up. There was no difference in one-year follow-up outcomes in readmission rate, re-angiography rate, or ejection fraction among both groups. So our experience of 1 decade shows that adjunctive coronary endarterectomy can be considered as an acceptable tool in the armamentarium of the cardiac surgeons in order to establish complete revascularization and in order to accept more cases for CABG. Thank you very much.